welcome everyone. Everyone's filing in on the chat. I think we can probably get started. A very exciting event, and we want to get into it as soon as we can, so we can appreciate the great talks and the input from our speakers as we go ahead. So my name is Andrew Halayko, and I'd like to welcome you, depending on your time zone, with a good morning, a good afternoon, or a good evening, and welcome you to Climate Change and Lung Health, Challenges and Solutions After COP26. So this is a webinar presented by the American Thoracic Society International Health Committee, and I'd personally like to thank them for including me in part of the organization of this. I'm a professor, Andrew Halayko, at the University of Manitoba in Winnipeg, Canada. I'm joined today by my co-chair, Dr. Juliana Ferreira, an associate professor at the University of São Paulo. I'd like to thank the International Health Committee for developing today's program and webinar, as well as our distinguished panel of speakers for providing their insight into climate change and health. Before we begin, a few housekeeping notes and reminders. Number one, we've muted all the participants due to the large number of registrants we have, which is very exciting. So if you do have a question, we encourage you to submit that via the chat feature on the webinar platform. Please note that we are recording the webinar, and it will be made available to all registrants at completion. And there will also be an archived version of the webinar posted on the ATS website. So please feel free to share that link with any of your colleagues who you think must hear the great talks that we have today. So the aim of the webinar is to discuss the biggest challenges and possible solutions to mitigate the impact of climate change on global health. And my esteemed colleague, Dr. Ferreira, will now give you a brief overview of last November's United Nations Climate Change Conference in Glasgow. So I'll hand it off to you, Juliana.
Thank you, Andrew. Ben, can we share the screen? Thank you. So it's just a brief summary. Can we see next, Ben, please? COP26 happened in Glasgow in November 2021. It's the conference of the parties. It's the UN climate change political and economical conference, if you want to say that. It's an annual meeting that happens every year in a different country, with more than 200 countries sending representatives. We also have NGOs and observers from all over the world. And COP26 was supposed to happen in 2020, had to be postponed to 2021 because of COVID-19. And it was the first COP meeting after the 5-year cycle set by the Paris Agreement. Next, please. The Paris Agreement was signed. Ben, can we see next, please? The Paris Agreement was signed during COP21 in Paris in 2015, and it was an important agreement because it set the target to limit increases in average global temperatures to 1.5 degrees Celsius above pre-industrial levels by limiting CO2 and other greenhouse gases emissions. And it also required countries to send or submit national plans called the NDCs for how they would reduce emissions in order to reach that target. So all eyes were on COP26 because it was the first time that a COP meeting would be held after that 5-year cycle revising the Paris Agreement. So the Glasgow Climate Pact builds on the Paris Agreement and is also grounded on a lot of science, which is, I think, a progress. It recognizes the importance of the IPCC report. The IPCC is the Intergovernmental Panel for Climate Change. It's written by experts and scientists, and it recognizes the urgency for acting now, the impact of climate change that's already happening, and models what would happen to the Earth if increases in temperature were higher than 1.5 or 2 or 3 degrees Celsius. So can we see next, please? I think these are 5 important highlights from that meeting. First one, keeping the 1.5 degrees Celsius alive, although the president of the conference mentioned that it's alive, but it has a weak pulse, because in order to keep that target and still be able to maintain that target, all the countries and governments need to commit and act fast. And so another important point was that faster timetable for action was also set by that document. So there is also an agreement that during the next COP that happens this year in Egypt, so COP27, all countries will also have to submit stronger NDCs, so stronger plans on how exactly they are acting or planning to act to reduce emissions in order to be able to meet that target of 1.5 degrees Celsius. There's also important progress in terms of climate justice. The commitment of providing financial support to poorer countries. There is a commitment to offer $100 billion per year to mitigate and help poorer countries which are harder, heavily affected by climate change right now and might be even more affected if we don't halt increases in temperature. The document doesn't really go into the details on how that money would be deployed, but there is a commitment to come to those details by 2023. Two other items were a little more controversial. The first one is ending forest destruction, although the document mentions that we should halt and reverse loss of forests by 2030. The document doesn't really say how this would be implemented. There's a lot of concern that governments wouldn't be held accountable for that. And so there's a lot of concern that the details on how we would implement this recommendation needs to be set by the next meetings. And finally, another controversial item was how to deal with fossil fuels, which are very inefficient way of getting energy. But of course, there's a lot of political and economical pressures all over this item. The good point is more than 20 countries agreed to stop financing new projects using fossil fuels. I think the hardest point on that matter was that the use of coal to produce energy was supposed to be phased out, but instead at the last minute, the term changed from phasing out to phasing down, meaning that we will still have countries using coal to produce energy, which is of course a big emission, a big way of sending emissions into the atmosphere. So there's also a concern that this has to be changed in the next meetings. As we hear our panelists today talk about the consequences of climate change on lung health as we speak, I think it's really important to understand that we all should be concerned with what happens and what is decided during those political meetings, and that we all should become advocates of climate change in order to stop the consequences that are already happening. With that, I'll stop and turn over to Andrew again, so he will introduce our speakers today.
There you go. Thank you, Dr. Ferreira, Juliana. So the webinar will feature 3 speakers. All will give wonderful talks. We'll do them in sequence, and we'll take questions through the chat when they're completed. Our first panelist will be Dr. Maria Jose Rosa. Dr. Rosa is an environmental epidemiologist and assistant professor in the Department of Environmental Medicine and Public Health at Icahn School of Medicine at Mount Sinai. She'll be followed by our next panelist, Dr. Hasan Bayram. He's a professor in the Department of Pulmonary Medicine at Halk University in Istanbul, Turkey. And our final speaker will be Dr. John Balmes, Professor of Medicine and Environmental Health Sciences at the University of California, San Francisco. So we'll begin all 3 presentations now. Please put your questions in chat as we go through for the discussion at the end, and we look forward to hearing from you. So Dr. Rosa, I think we hand off to you at this point.
Hi, I am Maria Jose Rosa, and I am an environmental epidemiologist and an assistant professor in the Department of Environmental Medicine and Public Health at the Icahn School of Medicine at Mount Sinai. Thank you to the International Health Committee of the American Thoracic Society for inviting me to give this overview on the impact of air pollution on lung health. During this webinar, I'll cover sources of both outdoor and indoor air pollution. I will describe the major outdoor and indoor air pollutants we measure, and I will touch on how climate change and air pollution are linked. I will also discuss both acute and chronic lung health effects of these pollutants, and I will talk a little bit about my research on windows of vulnerability to air pollution exposure. There are both anthropogenic and natural sources of outdoor air pollution. One of the largest ones is, of course, fossil fuel combustion for motor vehicles for heating and energy generation. Industrial and agricultural processes and waste incineration can also generate air pollution. Dust storms and volcanoes are some natural processes that can also generate this type of pollution. Probably the largest source of indoor air pollution around the world is the burning of solid fuel for cooking and heating, and this includes wood, charcoal, coal, and agricultural residues. Tobacco smoke is also an important source of indoor air pollution, and fireplaces, burning of candles, incense, and mosquito coils can also contribute to indoor air pollution. But we know that indoor and outdoor air pollution are also linked. Approximately 2.8 billion people rely on solid fuels for cooking, and solid fuels comprise about 10 to 15% of the total fuels used worldwide. Household cooking with solid fuels contributes significantly to outdoor air pollution as well. You can see this depicted in the maps to the right, showing the percent ambient air pollution attributable to household cooking. The darker red color indicates a higher contribution, and this is particularly evident in regions of the world with a higher use of solid fuels. Human-induced changes to the global climate system are mostly driven by the burning of fossil fuels and agricultural production with the release of methane. Weather patterns strongly influence the spatial and temporal distribution of air pollution concentrations, so climate change might impact air pollution in this way. But we also think that climate change could impact emissions themselves. For example, emissions may increase in response to climate change if there's a greater need for heating or cooling. When speaking about air pollution, we usually refer to various air pollutants that may all be emitted during these processes. For outdoor air pollution, we generally measure particulate matter, which is in fact a complex mixture of particles that can be solid, liquid, or both. It can also vary in size, composition, and origin. You can see in the left-hand picture a depiction of how small these particles can actually be. Generally, we refer to them by their aerodynamic diameter, and the most widely studied one is particulate matter less than or equal to 2.5 microns in diameter, or PM 2.5. The figure on the right depicts the regional deposition of particulate matter on the airways based on their aerodynamic diameter. The deposition of inhaled particles in the lung is determined by their length, width, shape, density, and by the anatomy of the respiratory tract. These parameters determine the aerodynamic behavior of particles in the conducting airways, as well as their probability of deposition and retention in the distal lung. Other important gaseous pollutants are nitrogen oxides, typically emitted from power plants, industry, and motor vehicles, carbon monoxide and black carbon or organic carbon, which are released during the incomplete combustion of fuels and are particularly important when assessing household air pollution, sulfur dioxide, which is released during combustion of sulfur-containing coal or oil and during industrial processes like the smelting of sulfur-containing ores. Ozone is a secondary pollutant created from the chemical reaction of nitrogen oxides and volatile organic compounds in the presence of sunlight, as is depicted in the cartoon to the right. Particulate matter, nitrogen dioxide, carbon monoxide, sulfur dioxide, and ozone are all criteria pollutants used in air quality guidelines by the Environmental Protection Agency of the United States. There are several potential biological pathways for the respiratory effects of these pollutants, including but not limited to respiratory tract injury, inflammation, and oxidative stress. activation of the sensory nerves in the respiratory tract, and it can also increase allergic sensitization by serving as adjuvants. Acute exposure to these air pollutants can produce irritation of the mucous membranes, including eyes, nose, and throat. They can cause cough, wheeze, chest tightness, increase airway hyperresponsiveness to allergens, increase incidence of acute respiratory illnesses like cold, pneumonia, and otitis media. They can also be associated with tracheobronchitis, and they are also associated with exacerbations of chronic lung diseases like asthma, including emergency department visits, hospitalizations, and increased medication use. In my next few slides, I'll provide some examples of the epidemiological evidence of these effects. In this study, concentrations of PM2.5 elemental carbon, which is a component of PM2.5, nitrogen dioxide, and ozone were measured via fixed sites or through personal monitors carried by a cohort of asthmatic adolescents in New York City. This figure shows that the association between short-term exposure to elemental carbon particularly was associated with a higher risk of cough, wheeze, and total symptoms in this cohort. In this slide, we show results from a study by Kirwa and colleagues, which reported results from their analysis of adults enrolled in the MESA cohort in the United States. They found that higher short-term exposure to PM2.5 and nitrogen oxide were associated with increased risk of symptomatic acute respiratory infections among the adults enrolled in this cohort. They found this association only with short-term exposure, not with exposure a year prior to the examination. Strickland and colleagues examined emergency department visits for asthma or wheeze among children aged 5 to 17 years from 41 metropolitan Atlanta hospitals during the period of 1993 to 2004 and linked them to ambient air pollution concentrations. Depicted here is the dose-response association between multiple pollutants, including ozone, nitrogen dioxide, and carbon monoxide, and a higher risk of emergency department visits for pediatric asthma in this area. Chronic exposure to air pollutants has also been associated with multiple adverse lung health outcomes, including decreased lung growth, impairment of pulmonary function, increased susceptibility to chronic obstructive lung diseases, including asthma, pulmonary fibrosis, and lung cancer. Shown here is work from Siddhartha and colleagues in which they examined household air pollution exposure and chronic obstructive pulmonary disease or COPD outcomes in 13 resource-poor settings in Latin America, Sub-Saharan Africa, and Southeast Asia. As shown in the figure here, participants with household air pollution exposure, depicted using the dashed line, had a higher prevalence of COPD than those without the exposure, which were depicted using the solid line. Although the prevalence of COPD between the participants with household air pollution exposure was higher at any age when compared to those without the exposure, the difference by household air pollution exposure status was greater at older ages. And we see these results also in children. Rice and colleagues estimated long-term exposure to PM2.5 and black carbon and assessed lung function in mid-childhood in a cohort of children in Boston. They found that estimates of long-term exposure to air pollution, including also proximity to major roadway and PM2.5 and black carbon measured in the past year and in their lifetime, was associated with lower forced vital capacity in this cohort, even at relatively low pollution doses. Similarly, the PIAMA study in the Netherlands examined incidence of asthma from age 1 to 20 years and linked it to air pollution measures, including nitrogen dioxide, PM2.5, PM2.5 absorbance, PM10, and PM2.5 to 10 in early life. Overall, the investigators found a higher incidence of asthma until the age of 20 years, with higher exposure to all of these pollutants at the birth address that were persistent with age. Reductions in air pollution can also have a positive impact on lung health. Shown here are results from the Children's Health Study in California, in which they sought to link long-term reductions in air pollution due to changing laws in California and lung function in children. They assessed lung function at age 11 and 15 and calculated lung function growth for that period. They reported improvements in 4-year growth for both forced expiratory volume in 1 second and forced vital capacity. And these were associated with declining levels of nitrogen dioxide, PM2.5 and PM10. And they saw this across all the communities in which their participants were recruited. And to touch a little bit on the windows of vulnerability of lung disease, we know that lung development begins in utero through a carefully orchestrated sequence of events. And according to the developmental origins of health and disease, or DOHAD hypothesis, events experienced during critical periods of development can impact health in ways that are not apparent until much later in life. And the reason why we're interested in these periods is that we think relatively low dose environmental exposures, including air pollution, experienced during the prenatal period and in early childhood, can alter the maturation of organ systems and also affect different biological processes and systems, including the hypothalamic pituitary adrenal axis, and oxidant-antioxidant balance, the autonomic nervous system, immune function. And these impacts in both pregnancy and childhood can impact developmental trajectories, which can lead to development of disease later in life. And here is an example. Here we show associations between daily PM2.5 exposure starting in utero and respiratory symptoms in our cohort of children living in Mexico City, which has a very high level of air pollution exposure. We found that exposure to PM2.5 from gestational week 14 through postnatal week 18 was associated with a higher risk of reporting AirWheeze at age 6 to 8 years. And we also observed a critical window of PM2.5 exposure between postnatal week 6 to 39 that was associated with a higher risk of current wheeze or wheezing in the past 12 months at age 6 to 8 years, potentially showing that exposure during these critical windows may lead to effects later in childhood. And the reason why we're interested in these time periods is that in the life course models of lung disease, risk increases because of the sequential effects of early environment on development and growth, setting different growth trajectories, as shown in this figure. This is followed by an age-dependent decline in plasticity and more modest responses to environmental challenges. In this life course model, disease risk rises exponentially over time, peaking late in life, which means that a small risk reduction during the plastic early life stages will have the greatest public health benefit, which is why we're interested in examining these vulnerable periods, which may be more amenable to a public health intervention. And I'd like to conclude with this figure from the document from the World Health Organization titled Preventing Disease Through Healthy Environments, a Global Assessment of the Burden of Disease from Environmental Risks. Several lung diseases, including infections, asthma, and COPD, which we have spoken about earlier in the webinar, have a high preventable burden of environmental risks, like air pollution. So reductions in air pollution would clearly benefit not just the environment, but health worldwide. And I want to thank you, and here is my contact information.
Hello, my name is Hasan Bayram from Koç University, Istanbul, Turkey. Today I'm going to talk about climate change and the impact on lower and middle income countries. But before starting, I'd like to thank to the American Thoracic Society International Health Committee, as well as Dr. Ferreira, for organizing this webinar and inviting me. In my talk, I will briefly mention the low middle income countries index in definition, and I will talk about the vulnerability to climate change and the water shortage problem, drought, and land eradication, and desertification, which impact low and middle income countries a lot, and which results in falls in crop yields, food shortage, and malnutrition in these countries. And I will talk about the extreme weather conditions, which really hit these countries more severely, and the capacity of these countries for dealing with climate change. Then I will summarize my talk. As you see in this map by OECD, classification of countries' income classes, as you see, lower middle and low income countries are usually located in Africa, in South America, Middle America, and the Middle East, and as well as in Asia. And as you know, vulnerability to climate change is an important issue, especially elderly ages and children are more susceptible to climate change, and the conditions such as pregnancy and working outdoor again affect your susceptibility to climate change. Again, having chronic disease such as cardiopulmonary and cerebrovascular disease make you more susceptible. But the topic of my talk today is living in regions susceptible to climate change and living in low and middle income countries. Lack of capacity to cope and adapt make you more vulnerable to adverse effects of global climate change. Looking at this map of climate change vulnerability index in 2015, as you see, the top 9 countries suffer more from global climate change are located, as you see here, mostly in Africa and in Southeastern Asia. And the freshwater availability, of course, it's very important, and this suffer a lot from global climate change. Looking at the vulnerabilities of freshwater resources worldwide, these water basins and rivers are located in Northern America and in the west part of South America, but mostly in Africa and Mediterranean basin, in the Middle East, and Near Eastern and Southeastern Asia. And it's estimated that about 1.5 to 2 billion people live in these basins. And of course, aridification of land, drought, and desertification is an important issue, especially in low and middle income countries. It's estimated that in the last 4 decades, about 50 to 63% of global land resulted in degradation. In the dry lands, due to drought and desertification, 12 million hectares of land are estimated to transform into new man-made deserts each year. The hotspots include Africa, Middle East, south of Ecuador, Southeast Asia, and South China, where mostly low and middle income countries are located. And of course, this have a severe effect on health parameters. As you know, in this recent study, we looked at the effect of desert dust storms and meteorological factors on respiratory disease in Southeast Turkey, where we see more sort of desert dust storms from especially Middle East deserts as well as Sahara. And we also see higher temperatures in southeast of Turkey. So the study covered the period of 2009 to March 2014, and we looked at the effect of sand dust storms, PM10, and temperature in approximately 650,000 patients with respiratory disease. As you see here, desert dust had a significant impact on mortality due to asthma and COPD, as well as hospitalization due to asthma, COPD, and respiratory infections. Similarly, there was a post-association between maximum temperature and mortality due to respiratory infections, as well as hospitalizations due to respiratory infections, as well as pulmonary embolism. And the effect of all these climate change related parameters and issues such as desertifications, aridifications of land, as well as temperature change has an adverse effect on crop yield. As you see here in this graph, when temperatures, local temperatures are increased, we see that the maize yield in mid to high latitude is decreasing. This is more prominent in low latitude areas, as you see here. The same is for wheat yield in mid to high latitude areas, as well as in low latitude areas, suggesting that when temperatures are increasing, the crop's yield is significantly decreased. And of course, this causes the undernourishment problem worldwide. Looking at the, especially in low-income countries, looking at the prevalence of undernourishment in the world between 2005 to 2017, according to figures by Food and Agriculture Organization. As you see here, this is more prevalent in Africa and leading to 20.4%. And the same for Asia with 11%, but more prominent in Southeastern Asian countries, as well as Central Asia and Southern Asia countries. Again, in Latin America and the Caribbean, we see undernourishment markedly in Caribbean countries. And looking at the global number of deaths attributable to risk factors, including child and maternal malnutrition, which is a consequence of food shortage, as you see here, this has impact on deaths due to infectious disease, including respiratory infections and TB, both in females and males population. Of course, extreme weather conditions affect countries worldwide, but as you see in this map, the most affected countries between 2000 and 2019, as reported by German Watch, are from Puerto Rico, Myanmar, Haiti, and all countries in the class of low and middle income classification. In only 2019, it has been shown that cyclones, hurricanes hit Mozambique, Zimbabwe, Malawi, and Bahamas. Severe floods and landslides hit Afghanistan that year, as well as South Sudan. Again, monsoon season affected Bangladesh, Pakistan, India, as usual. And heavy rains, massive flooding hit Niger that year. Wildfires destroyed 2 million hectares of forest in Bolivia in that year. And these, all these climate change related issues cause migration, social stress, and war, especially in low and middle income countries. This put millions under the stress. It's estimated that the number of people vulnerable to migration, as called climate change migrants, vary from 25 million to 1 billion people by 2015. And according to a workshop report by American Thoracic Society and European Respiratory Society, such massive migrations can lead to increases in respiratory infections, including TB, sleep-related disorders, and allergic disease such as asthma and COPD. And global climate change leads to economic losses, especially due to climate-related events. As you see here, as the intensity in US dollars as a percentage of GDP, looking at the situation in low-income and high-income countries, as you see here, the losses was significantly increased in lower and lower middle-income countries from 2010 to 2016. But more important, the losses from these countries are mostly uninsured losses, economic losses. When you look at the high-income countries, yes, they have losses, but still in percentage of GDP, this is lower than low-income countries, and the losses is mostly insured losses. This graph shows the international health regulations capacity scores by WHO regions. As you see, this capacity in dealing with global climate change, especially human resource capacity, is decreased in Africa region. The preparedness capacity is much decreased, as you see here in Africa, as well as the response capacity to global climate change is decreased in Africa. Spending on health and health-related adaptation and resilience to climate change is important. When looking at the total expenditure, this is, of course, much higher high-income countries. That means that these countries spend more in their health and health-related adaptation and resilience to climate change. But when looking at the percentage of these expenditures to the GDP of these countries, as you see here, this is markedly increased in low-income and lower middle-income countries, demonstrating that these countries spend a substantial amount of their GDP in their preparedness and resilience to climate change. As you know, COP26 was organized in Glasgow last year, and there were some promises for low and middle income countries. And they decided to support developing countries to scale up the clean power, and developed countries committed to raise 100 billion every year as a target in climate finance, mostly to support developing countries. International Monetary Fund confirmed that proposed resilience and sustainability trust will provide a long-term finance at low rates to low-income and vulnerable middle-income countries. But let's see, let's hope that this will really come through. Although I try to discuss the situation in low and middle-income countries, but still there is a lack of data from these countries. As concluded in the nice review by Green et al., there is not sufficient data, and although heat wave, as they conclude, the heat waves have the most severe impacts on vulnerable populations, relatively few studies have investigated their impacts in low and middle-income countries. In summary, lower and middle-income countries are usually located in vulnerable regions, as I've shown, and these countries suffer more from decreased crop yield and malnutrition. Extreme weather events hit more these countries, and their capacity for resilience to climate change is lower comparing to developed countries. COP26 declarations are promising, but let's hope that they will really come through. And we certainly need more actions and support to increase the capacity of low and middle income countries. And another issue, we certainly need to do more research in these countries to see the scale of the problem. I thank you for your attention. Thank you.
Hi, my name is John Balmes, and in addition to being faculty at University of California, San Francisco, and Berkeley, I'm also the physician member of the California Air Resources Board, which is the state agency responsible for air quality, regulation, and climate change mitigation policy. And I'm happy to talk to you today about wildfires and lung health. So many people around the world were shocked at the Camp Fire in Northern California during November 2018, which destroyed the town of Paradise and fouled the air, as you can see from the satellite picture, of all of Northern California. This really caused many residents of Northern California to realize that catastrophic wildfires could cause a major problem with regard to air quality and lead to consequent health problems. In August of 2020, the entire West Coast, from Northern California to Oregon to Washington to British Columbia, was fouled by multiple smoke from multiple wildfires. Each one of these red dots in the satellite photo is a wildfire. And I'm just showing you data from the US, but this is happening in other places in the world like Australia, Portugal, Russia. So there are increasingly more acres burned by wildfire as drought and heat lead to conditions, climatic conditions that favor wildfires. And like I said, it's not just the US. The Australian bushfires of the 2019-2020 wildfire season, brush fire season there, caused 46 million acres to be burned. That's 10 times what burned in California in 2018, which was the worst year for California in terms of total acres burned. Many animals died. Homes were destroyed. And again, incredible air pollution was generated. This satellite picture shows multiple fires and how you can't even see New Zealand due to the smoke. There was poor air quality in Sydney, Melbourne, Canberra, and New Zealand. And not only did the air quality suffer, but the emissions from wildfires actually are climate forcing. And the Australian Environmental Protection Agency estimated that the emissions from that fire season were equal to 12 months of emissions from man-made sources. And this slide shows the feedback of wildfire emissions increasing risk of climate change, because some of the emissions are climate forcing, in addition to the effects on air quality. So there's a double whammy, if you will. Poor air quality with health impacts, which I'm about to talk about, but also climate forcing emissions. And what are those emissions? Well, the primary pollutants emitted, particulate matter, carbon monoxide, nitrogen dioxide, polycyclic aromatic hydrocarbons, and volatile organic compounds, are very similar to tobacco smoke without the nicotine. That's why they're so potent at causing health effects. There are also secondary air pollutants, secondary organic aerosols generated in the atmosphere. And ozone is also generated because of the nitrogen dioxide that is emitted. Now, there's clear evidence of an association between wildfire smoke and respiratory health. Asthma exacerbations have been associated with higher wildfire smoke in nearly every study. This is also pretty much true for exacerbations of COPD and other lung diseases. And there's growing evidence of a link between wildfire smoke and respiratory infections. One example of such a study was from Southern California, where they looked at pediatric respiratory healthcare. These investigators examined the associations between wildfire-specific fine particulate matter and healthcare utilization in San Diego County in Southern California. And the study was striking because a 10 microgram per meter cubed increase in PM 2.5 from non-smoke sources, like motor vehicles, was associated with a 3.7% increase in ED and urgent care visits for respiratory conditions. But PM 2.5 from wildfire smoke was associated with a 30% increase in visits, suggesting that in terms of respiratory outcomes, that wildfire smoke may be more potent than other sources of fine particulate matter. Now, I said I was going to focus on respiratory health, but there's increasing evidence that wildfire-specific fine particulate matter is associated with cardiovascular healthcare utilization as well. And this study was done using data from the 2015 wildfire season in Northern California, which was not a particularly bad year compared to recent years. And they found the expected increase in respiratory condition healthcare utilization. There was an 18% increase, but they found similar effects with regard to cardiovascular outcomes like heart attack, heart failure, stroke. And I showed you that satellite picture from August 2020. So that month was the worst continuous air quality that Northern California had ever seen, from second week in August to the second week of September. And some investigators from Stanford have looked at how many excess deaths occurred during this 1 month period of bad air quality. And all the red peaks above the baseline, and the baseline is not zero. The baseline was the average fine particulate matter from non-wildfire sources between 2015 and 2019. And so all the red peaks above the line represent excess exposures, which were quite high. And this led to an estimated 1,200 to 3,000 deaths, mostly due to cardiovascular outcomes, but some pulmonary as well. Now, other health outcomes have been associated with wildfire smoke, including adverse birth outcomes, especially low birth weight, but preterm birth is also potentially associated. There's mental health issues from poor air quality, evacuation, and then there's unknown chronic effects from recurrent exposures based on what we know about non-wildfire PM 2.5. And this is a cartoon showing how small PM 2.5 is, makes it down to the deep lung. And this is showing the red spheres depicting PM 2.5 versus a human hair, which is about 60 microns. So these are very small particles. They have been associated with metabolic outcomes like diabetes, obesity, cognitive decline in older individuals, neurodevelopmental problems in young children, decreased lung function, and the health of pregnant mothers. Now, very few studies of wildfire smoke have involved chronic exposures. Really, the only population that has been studied with regard to recurrent or chronic exposures are wildland firefighters, who are particularly healthy individuals. And of course, that bad air quality of 2020 coincided also with the COVID-19 pandemic. And a study from Harvard of 92 counties in the Western US showed increased risk of both cases of coronavirus and COVID-19 deaths in association with wildfire-specific PM 2.5. So we certainly need to heighten our readiness and resilience in response to these catastrophic wildfires. We need improved planning of the public health infrastructure, and healthcare providers need to know how to advise our patients how best to deal with poor air quality from wildfire smoke. And some basic information is to stay indoors with windows closed, so-called shelter in place, to provide filtration and ventilation, which can be done by relatively low-cost portable HEPA filtration devices. I have two in my home in Berkeley, California. And then if you have to go outside, wear appropriate respiratory protective gear, which really N95 respirators, which many of us know from the requirements for protection from SARS-CoV-2 are the most effective personal protective gear to wear. And unlike for hospital or clinical use, N95s with an exhalation valve are fine to use because we're only worried about protecting the wearer from inhaling wildfire smoke, not exhalation. Who's at greatest risk? Outdoor workers. Of course, the general public can be affected, but especially persons with heart and lung disease and young children. We have some research needs with regard to wildfire smoke. We need better assessment of the relative toxicity of wildfire smoke PM 2.5 compared to non-wildfire PM 2.5, though I showed you there's some suggestions that it has more respiratory toxicity. We don't know the effects of recurrent high-level exposures to wildfire smoke, fine particulate, especially among the most vulnerable populations like the very old and the very young. And we need better mechanistic understanding of how PM 2.5 increases risk of lower respiratory tract infection. So in conclusion, the duration of the wildfire season is longer and catastrophic wildfires are increasing in frequency due to climate change. And this is not just in the US, but around the world. Acute respiratory effects are well documented, but new studies suggest acute cardiovascular effects as well. Long-term effects of high or recurrent exposures need further study, and the risk of COVID-19 may be increased by wildfire smoke and complicates wildland firefighting. Thank you.
Had some wonderful talks. Thank you all. And we'll proceed to questions. I've got a couple myself, and so maybe I'll steal the chance to get those in. And Dr. Bayram, I found your presentation quite fascinating. I found myself starting to think about the links of climate change and the stresses on society with respect to mental health, and perhaps the links of mental health issues, climate change, and then how it translates into respiratory health. And I'm wondering if you've got any insight there as to whether the social impact, if I can call it that, or wellness impact, mental health of climate change has a secondary effect on respiratory health.
Yeah, thank you very much for this great question, which is quite important, actually. Yeah, I mean, as we all know, if you are mentally ill, if you have mental problems, this really impacts all your function, all your systems. Especially for the case of respiratory disease, as we all know, especially asthma is closely related to the mental condition, whether the person has a sort of stress, no matter what the source is. So yes, I should say it's closely related to respiratory disease as well. And also this impacts the how do you say the lifestyle, the life condition, and these people are usually on the move and in crowds, sometimes by walking, sometimes under bad weather conditions. The recent situation in Ukraine, and we are just close to Syrian border. We see that very clearly from migrants from I should say Syria, from other Middle East countries. And when you think of this is yes, there are some conflicts, wars there, but this cannot be just with no relation with climate change. And it's thought that really maybe the main reason for these conflicts could be the consequences of climate change, the water shortage, the increased desertification in those regions, which has an impact on the people's income and the society's daily life. This is quite important, actually. Thank you.
Yeah. Thank you for your answer. Juliana, did you want to take the chat question, or you're happy with me continuing?
I think I'll read one of them.
Okay.
There's one question here that I love because it was my question too. I think I would ask Dr. Rosa to answer first, but I would like to hear Byron as well. It's the person who sent it said it's a two-part question. What do you understand as the role or responsibility of the world's health workers in responding to climate change? And the second part, so what is our role? And the second part is, to what extent do you think educational institutions tasked with training health professionals are preparing health workers to meet this responsibility? So Dr. Rosa, please.
That's a great question. And I think it varies, in terms of like whether you're an investigator, you're a clinician, I'm coming more from the investigator side, and, working as an environmental epidemiologist. Obviously, what we want to do is, get the data that actually, gets changes in policy, showing that, we know that these emissions are associated with these outcomes, and try to sort of impact, the work that way. And so, that it's, because I think with climate change, it just seems like such of a big problem that trying to say, okay, so we know that these emissions are associated with this, and if we reduce them in this way, we know that it not only will help, impact climate change, but we also know that it will reduce the burden of disease, not only respiratory, but cardiovascular, as our other speakers touched upon. So I think that's a big part of it. Obviously, clinicians, they deal more one-on-one with the people who are coming in, the kids who might be coming in for an asthma attack because the wildfires, or because of other kind of environmental events related to climate change. And in terms of like education, I know at least here, even in our institution, we have a pediatric environmental health specialty unit, which actually specializes in clinicians being trained in order to kind of communicate to the patient's environmental health risk, which I think is something that would be great to also do in terms of climate change, related to temperature and how this affects emissions. So I think, so I think we all have kind of, the duty to kind of help educate, not just our peers, but, kind of like the public that we come into contact with.
Dr. Bayram, can you comment on how is this happening in your view in Turkey, for example, in Turkish institutions?
Yeah, thank you very much. This is a very important issue, actually. And I'm a pulmonologist, so I see patients. I mean, we clearly see the situation in the outpatients. On those days, we certainly see more patients, applying for pulmonary disease due to COPD or asthma. So we clearly see that impact on our daily lives, really, especially in my previous place in the southeast of Turkey. There used to be desert dust storms from, as I said, from especially the Middle East deserts. So you could clearly see this. So as a physician, we usually advise patients to stay indoor, especially during dust storm days, as well as during heat waves, to stay indoor and to, if they have, of course, this is not always possible, especially in, lower income countries, to turn on their air conditioning system. So this could be something, and it has been shown that it could be quite protective, actually, for patients. And we may need to modify their medication, because they may need more inhaler, especially for asthmatic patients and for patients with COPD. And we need to warn healthcare workers on those days. We need to warn hospitals and authorities, especially health authorities. And if we foresee these, let's say, heat waves, and which is usually possible these days, and desert dust storms, because there are, dust transport maps that you could clearly follow from different sites of the meteorology offices, etc. So an early sort of warning system could help health authorities and patients, to get ready to get protected from adverse effects of climate change. And yes, as Dr. Rosa mentioned, education is something really important, because some people still think that, okay, these are all environmental issues, they are out of our health care or our duties of a physician. But this is not true. We see this in our daily practice. So this should be on the curriculum of medical schools, even high schools, or in early ages. And of course, yes, using HEPA filters inside, it's a personal protection. But I think the most important thing is really to do something globally. I mean, to keep the targets of COP26, and to think more globally, and to collaborate, especially with countries with have lower sort of sources to combat global climate change.
Yeah, that's a great point. It always worries me that I think a lot of people in the community, our patients and public, may see these events, but they don't really connect the dots and say this is happening because of climate change. I think we need that step. I think people need, and maybe what the question is addressing is our role as helping our patients and the community, being advocates to help people see that this is already happening. Because I think I think a lot of people would say, well, this is happening in 20 years and I don't worry about this. I need to pay my bills today. But if you know this is happening today, it's happening to you, happening to your kids who are compromising their lung growth, then this is something that people would like to act. And I feel like I don't think health professionals in general are doing a good job at being advocates of what's happening. I have the impression that the population doesn't really connect this to health events with climate change yet.
Yeah, I think we have a great role really in this, because when you explain something with health consequences, you are likely to maybe motivate people and authorities, to do something on this. I think this is a critical issue, really.
Other questions here. Do you believe that aspects of climate change, environmental pollution should already be questions incorporated into the routine anamnesis in healthcare, primary healthcare? Do they help in the analysis of consequences? So should we be asking questions about pollution exposure or wildfire exposure or sandstorms exposure when we evaluate our patients? I think that's the question then. Dr. Bayram, is this something you usually ask your questions? Here in Brazil, go ahead.
Yeah. I mean, sometimes patients say it themselves without you asking, because they say, okay, I was good, I was doing well actually, but these days, this polluted air or this dust storm really, make my breath worse, so I cannot breathe. So I try to stay inside. I mean, if they are aware of that, which they are usually, experience this. Yeah, I think it's important to ask this because sometimes this could be, something which provokes their, disease. Because when there is an exacerbation of, let's say, COPD or asthma, so you are always seeking for an underlying, cause of being an infection or restarting cigarette smoke, which is case sometimes for COPD. So I think, yeah, we should keep in mind to, asking about the, weather condition and pollution. Yes, I think we should ask.
I think this is something we teach our fellows here in São Paulo to ask about indoor coal burning or biomass burning. It's something that really we have in Brazil and other countries in Latin America. So it's something we have incorporated in our anamnesis.
Yeah, exactly.
Dr. Rosa, we have a question from Juliana. Can I jump in and tie together a couple of things that I think will bring what you said, what Maria presented, and one of the questions is touching on. And so specifically the concept of preventable burden from environmental risk that is high for asthma and COPD. That's an interesting concept. I love the way Maria showed it. You provided an overview of the targets that COP26 has got, and we've got a question that's focused on the fact that COP26 is talking about phasing out coal, not eliminating it. And so the question is, should health outcomes be a stronger element of what the next COP meeting deals with? And perhaps are the targets we're creating and that COP26 came up with, are they even sufficient to mitigate this or to have an impact on this preventable burden of asthma and COPD? I think it's great the way the three have come together. So maybe you could discuss that amongst yourself.
I think that's a great idea, because I think a lot of these targets are a little nebulous concepts, for kind of the lay audience, keep it at 1.5 degrees, but you're like, but what does that mean for me, in my daily life? Yeah, I think what makes sense is like, well, if we keep, the temperature at this, and we reduce emissions by this much, we know that we are preventing, X number of, children from developing asthma or developing COPD, so I think that would make it a little bit clearer to the public that, okay, there's a tangible benefit to this. Like, obviously there's annual benefit no matter what, but this I think more relates to, okay, I have respiratory disease, so I know that these can actually like impact me, or even cardiovascular disease. We know emissions are associated with a host of diseases, not just lung related. So I think it'd be a great way to kind of, make the message more appealing, I think.
I have a second question on that. You showed very interesting data on reversing the impact in lung growth and lung function with reduction of air pollution. Do we have any data on reductions of biomass or fuel burning inside homes in low and middle income countries and the impact for lung health? Do you know?
Yeah, so I know there's especially a lot of work being done, I know, in Ghana, because there are some colleagues who have done, kind of the clean cook stove project, to try to switch out. I think that and I think there's some good data out of kind of switching, and I think that other paper that I showed from Start and colleagues showed that, the people who use the clean fuel versus the biomass fuel. So I think it's clear there's an impact. Where the problem, I think, it's kind of, it's money always, because I know, like in Ghana, the problem has been like, okay, you give them the stove, but then like, the gas costs, X amount of percentage of what they earn. So it's more, I think that's when the kind of money comes in from like the government or that say, okay, we're going to try to make sure that this is actually not just for this study, but that's actually something that can be kept long term. I think that's sort of the issues that have come up with like kind of like the biomass kind of studies.
There's another question on the chat. I think for maybe Dr. Bayram could take this one. Are the potential effects of climate change on respiratory health different from overall effects of all aspects of health among different regions of the world? And then the person says, in other words, are some countries less susceptible to respiratory health impact, but more to other health issues from climate change? And I think this is something you touch on your talk.
Yeah. I mean, it depends on the risks that you are exposed, and it depends on yes, the location that you live. I mean, sometimes it could be malnutrition, which really impacts all health aspects. I mean, from gastrointestinal disease to respiratory disease, as this is the case for the respiratory infections, for the TB. Sometimes it could be heat waves that could increase, direct sort of impact on mortality due to yes, respiratory disease, but as well as cardiovascular disease, as well as stroke. So this has been shown in other studies. But the issue, especially for the protection, is important. I mean, if you have sources, I mean, if you have, let's say, on those days, especially during the heat waves, if you have, cooling sort of places for public, if you have air conditioning inside your house, so this could be protective. So in a way, it depends on really your sources and your facilities. And of course, today we mostly talked about the respiratory effects, the cardiovascular effects. But as I said, yes, all system disease could be affected by climate change, directly or indirectly.
Yeah, thank you. Well, I think our time is up. So I want to thank the panelists, my co-chair and ATS for organizing this webinar. And thank you everyone for being here. We want to remind you that this session is being recorded and it will be available at ATS's website. Thank you for being here and see you soon. Bye.